We're going to go ahead and get started on the webinar. Feel free to send us a Q&A or a chat if you have any trouble connecting to the audio or if you have any questions along the way. Welcome everyone to the second of 4 webinars on Interprofessional Collaborative Practice Program Evaluation, all of which are based on the National Center's Practical Guide number 5, Incorporating IPCP Teamwork Assessment into Program Evaluation. Hopefully you've all already had a chance to listen to the opening webinar, which was led by lead author of the guide, Dr. Connie Schmitz, and which sets the stage for today's webinar. The National Center is a jointly accredited provider of interprofessional continuing education credits for the healthcare team. This statement describes the nature of this presentation and the 1 hour of interprofessional continuing education credit available to those who did select that option at the point of registration. If you have questions about continuing education, please let us know in the Q&A box, and we will answer those questions at the close of the webinar. This slide simply states that our presenter, Lauren Collins, does not have a conflict of interest in this presentation. My name is Angela Wilson, and I'm the Education and Training Program Manager for the National Center. It's my pleasure today to introduce our presenter for the webinar, Dr. Lori Collins. Lori is a family medicine physician and geriatrician by training, and she's co-director of Jefferson's Center for Interprofessional Practice and Education, located at Thomas Jefferson University in Philadelphia, Pennsylvania. She is a Macy faculty scholar who has helped to develop a longitudinal IPE curriculum at Jefferson and worked with the Jefferson team to design a new 360-degree IPCP assessment tool, which is called the Jefferson Teamwork Observation Guide, or JTOG, and is available as a mobile app. She is passionate about IPCP implementation and assessment, and we are excited to have her join us as co-author on the National Center's Practical Guides, both numbers 4 and 5. I will now pass the ball and hand things over to Lori.
Thank you for the introduction, Angela, and welcome to our second of 4 webinars. Today, we will continue to explore some of the core evaluation design principles discussed in Practical Guide 5. As many of you know, the National Center's previous guides focused on IPCP teamwork and the assessment of individual learners, teams, or environments. Today, we build on that foundation, but shift our focus to the programs that you are all implementing to change the collaborative practices of individuals, teams, and organizations. Guide 5 could not have been written without the expertise of lead author Dr. Connie Schmitz and the 2 additional co-authors listed here, Dr. Barrett Michalek from the University of Delaware and Dr. Doug Archibald from the University of Ottawa. Barrett and Doug will be giving the 2 remaining webinars based on Guide 5 in May. And this summer, we will all join Connie in offering a half-day short course on program evaluation at the National Center's Nexus Summit, and we hope you can join us. Our purpose in writing Guide 5 was to help each of you who are involved in IPCP implementation do good evaluation work by writing an excellent plan. And by you, we mean persons with some level of accountability for an IPE program and/or who expect to have some involvement with the evaluation. So, as Connie presented in Webinar 1, Practical Guide 5 has 3 main components, as shown on this slide. Today, we're going to take a deeper dive into Part 2 of the guide to explore key components of designing an evaluation plan. We will use a Jefferson-based IPE program as an example of how to use the guide to help you walk through important design decisions to consider as you create your own evaluation plan. We hope that by the end of the hour, you will first be able to describe the Jefferson team's context for evaluation. Second, you will be able to apply the team's guiding evaluation questions to our hotspotting logic model and to explain some of the if-then thinking that drives our evaluation plan. Third, you will be able to explain the difference between broad and refined evaluation questions. And finally, you will be able to explain the relationship between refined questions, data sources, and data collection methods. For today's session, we'll provide you with a brief refresher on evaluation frameworks and the components of a successful evaluation plan. Then, we will introduce you to a real-world story of designing an evaluation plan of an IPE program here at Jefferson. We will spend about 10 minutes discussing our evaluation context. We will spend 10 minutes looking at our logic model and examining our if-then assumptions, and another 10 minutes discussing our process for going from broad to refined evaluation questions. For the next 10 minutes, we'll discuss ways to move from guiding evaluation questions to information needed and data sources. Finally, we'll take a few minutes to walk you through our own process for identifying our information needs and data sources. The remaining minutes are reserved for your questions and to allow time for discussion. So, what is an evaluation framework? As a refresher from Connie's webinar, an evaluation framework is the conceptual scaffold on which your program and its evaluation should be based. Some evaluation frameworks are generic and can be used across broad genres of programs, such as education, health, and social care. Others evolve from fundamental understandings or theories about the nature of change in particular settings. For example, theories of learning and teaching, theories about innovations and their diffusion, theories about teamwork and safety, and theories about organizational change in healthcare. As each of us begins to think about our own evaluation framework, it can be helpful to refer back to the Institute of Medicine, now named the National Academy of Medicine, or NAM, model from 2014. This model postulates that IPE occurs through an extended learning continuum, from pre-qualification or foundational learning to graduate education to continuing professional development. The model articulates intermediate learning outcomes for individuals and groups. It also includes more distal changes in health and systems outcomes, which are shaped not just by IPE, but also by enabling or interfering factors, such as professional and institutional culture, workforce, and financing policy. The National Center has adopted the NAM model as a guide for those of us who are evaluating programs and conducting research on IPE. The NAM model can really be seen as the mega framework, as Connie likes to call it, because it represents a broad level what the IPCP field as a whole is trying to accomplish. However, fortunately, for individual program developers and evaluators like me and perhaps you, we are not necessarily expected to do it all. Instead, we get to pick and choose which pieces of this bigger puzzle we would like to focus on. As you begin to think about your program evaluation, first consider a few questions. First, who is involved? Second, how does your program work? And third, what do you expect to achieve? After thinking about the MEGA framework, a helpful next step can be to break the evaluation plan down into discrete tasks. As you will see in Practical Guide 5, we have broken evaluation planning into 15 components seen here on this slide. Today, we'll do a deeper dive into the design section, or section 2 of an evaluation plan, and provide a real-world example to consider several of these important design components, including how to design appropriate guiding evaluation questions, how to identify information that is required for your evaluation plan, and how to select the most appropriate source or sources for collecting this information. After you've considered the context of your evaluation plan and answered each of the questions shown in section 1 of this slide, gather your evaluation team and start by thinking through each of the design questions here in section 2 of the planning tool. First, begin by asking, what are you trying to figure out, learn, or know? Second, what type of information would help you answer these questions? And third, what is the best source or sources to gather the information you need? If you haven't already started to complete the evaluation tool from Practical Guide, which is located in the appendix on page 65, this is a great time to pull it out and get started. As we go through our real-world example of design planning from Jefferson, think about specific design questions you want to answer at your own institution, how you can best answer these questions, and who or what is the best source for this information. Then use this tool and begin to fill out each of the boxes. And you'll see by the end of it that you have a full evaluation plan ready to go. Now, let's move on to our real-world example to show you how to think through applying the Practical Guide and the evaluation planning tool to create a comprehensive evaluation plan. For this webinar, we are going to look at a program called the Interprofessional Student Hotspotting Learning Collaborative, which I will refer to as Student Hotspotting moving forward to make it a little easier. The evaluation plan that is presented here was developed by a Jefferson team, including myself, Shoshana Six, who's the Associate Director of Jefferson Center for Interprofessional Practice and Education, as well as 2 third-year MD, MPH students, Charles Barron and Gerald Gibbons, who worked on this evaluation plan as part of their Master's in Public Health capstone project. Additional input on the evaluation plan came from key stakeholders in the program, including students, faculty from our internal IP research committee, clinicians, as well as leaders in the Jefferson Health System. In addition, we had external input from the Camden Coalition, as well as Dr. Connie Schmitz, the lead author of this Practical Guide. Before we can begin to discuss our own design decisions, however, we'll first provide you with a brief overview of the program. So first, a little bit of context for student hotspotting. Jefferson had been participating in student hotspotting with the Camden Coalition of Healthcare Providers since 2014. However, in May of 2017, we were selected to become one of 4 new national hotspotting hubs supported by a 2-year Robert Wood Johnson subaward. As a new hub, we needed to plan to significantly scale up our program and move from hosting one internal student hotspotting team to 8 internal teams, as well as 12 external teams from other institutions up and down the East Coast. In planning for this expansion, we wanted to create a new plan to evaluate the impact of the expanded program at Jefferson, and also begin to think about ways to capture the impact of the program at all of our participating hub institutions. For a little more background on hotspotting at Jefferson, we decided to apply to become one of the national hubs and participate in this expansion after hearing numerous anecdotal stories from our 3 previous cohorts of student hotspotting teams. Many of these students have reported that this program was one of the most meaningful experiences during their training at Jefferson, that it built significantly on their required core IP programs, and that it provided a perfect bridge to real-world collaborative practice. Over the years, students have reported how much they enjoyed working with their interprofessional colleagues and felt like they had made a difference in the lives of the patients enrolled in the program. In the year leading up to our application to become a hub, our evaluation team conducted over 40 meetings with current students, alumni, with Jefferson faculty and deans, with local primary care providers, care coordinators, and leaders from our Jefferson healthcare system. During these important meetings, we were able to get stakeholder buy-in to support an expansion of this IP initiative. So, you may be wondering, what was the problem that we wanted to address through expanding our student hotspotting program? As many of you are already keenly aware, a small set of patients termed superutilizers use significantly more healthcare resources and account for more spending on healthcare than other patients. As reported in the recent NAM report from 2017, 5% of patients account for nearly half of the nation's spending on healthcare. In Pennsylvania, superutilizers accounted for $1.25 billion of healthcare costs in 2017. Moreover, in the city of Philadelphia, where Jefferson is located, we have the highest number of superutilizers in the entire state of Pennsylvania. So, what is our program theory that's underpinning student hotspotting? We know from the current literature that superutilizers tend to be complex in both medical and social status, and in turn, often benefit from personalized care plans. Superutilizers frequently have complex relationships with the healthcare system, facing access and resource issues, and reporting negative perceptions of care received, in addition to their complex medical and social situations. We also know that strong teamwork has been linked to positive perceptions of care provided by patients, making an interprofessional, team-based approach to complex patient care an ideal fit. Therefore, our program hypothesis is grounded in the belief that high-touch, interprofessional, team-based interventions will improve the health outcomes for our complex patients and reduce healthcare system costs through improved stewardship of healthcare spending. You might now be asking, what exactly do student hotspotting teams do? As part of the program, interprofessional student teams work with faculty advisors, primary care providers, and care coordinators to identify and enroll local superutilizers into the hotspotting program. As part of the program, student teams assist patients in setting and accomplishing their goals and partner with their patients to create a sustainability plan for how to do so on their own after the 3-month intervention ends. Students also participate in a concurrent Mosaic curriculum consisting of educational videos, online workshops, skills sessions, and faculty-facilitated team meetings and debriefings. Hopefully, this overview of student hotspotting has provided you with a bit of detail about our program context. That is, our program's background, rationale, and theory. In many ways, these are often the easier steps in creating an evaluation plan, since I think everyone feels pretty comfortable with describing his or her own program and program hypothesis. But here's an important transition. Once we had committed to significantly scaling up this program, we had to take a giant step back and think about how are we going to evaluate this program. This is where we needed to take a breath, regroup, and ask ourselves a few key questions. What is the purpose of our evaluation? And what decisions do we want to be able to make based on the evaluation findings? At this point, our team took a closer look at the practical guide, and we began to think about how to create our logic model. First, we began by using the SIP model that Connie presented in Webinar 1 and looked more closely at our program's context, inputs, processes, and products. In terms of the purpose of our evaluation, we identified that we are interested in both formative and summative aspects of the program, and that we wanted to assess short-term and long-term impact of the program on students, on patients, and on Jefferson's academic and clinical pillars. We decided that our formative evaluation would focus on the level of interest among all participants, including students, staff, faculty, and patients for this high-touch interprofessional team-based approach. Additionally, satisfaction with the program design and the academic curriculum would need to be assessed to determine areas for quality improvement. For our summative evaluation, we wanted to understand the impact of the program on student participants, on enrolled patients, and on the local culture, both academic and clinical, at our hosting hub site at Jefferson. For example, we wanted to know if Jefferson students who participate in the program had higher rates of entering primary care fields or working with complex patients in their future careers. We wanted to know if patients enrolled in the program reported improvements in self-reported health and fewer hospital admissions. We also wanted to know if our health system would increase their financial commitment to the program if enrolled patients experience more cost-effective care. As we considered our SIP model, we tried to create an all-inclusive list of each of our inputs, outputs, and anticipated short and long-term outcomes shown in this diagram here. I remember when we showed this draft to Connie Schmitz, I think she may have secretly been horrified. In her very gentle way, Connie asked us to clarify our assumptions. She pushed us to think not just about what your program entails and how it operates, but why do you expect it to work? Essentially, she was encouraging us to create a clear logic model for our student hotspotting program. So we went back to the practical guide and looked again at this section on logic modeling. As you will see here, we then began to write out each of our three main if-then assumptions for students, patients, and Jefferson Health based on involvement in the expanded student hotspotting program. For example, here are some of our assumptions. In our model, we assume that if student team members develop good teamwork and communication skills and also increase their knowledge of and comfort working with super utilizers, then more students will progress to practice settings where they work with complex patients and experience less burnout, as well as increased empathy in caring for complex patients. We also assume that if patients enroll in the program, set personal goals, and create a sustainability plan for continuing self-care, then they will experience a decreased need for emergency department visits and inpatient utilization, increased outpatient utilization, improved self-reported health, all leading to long-term health improvement. Finally, we assume that if Thomas Jefferson University and Jefferson Health integrate this pilot program into the curriculum and increase their funding to sustain expanded hotspotting efforts, then Jefferson Health will see decreased utilization of inappropriate healthcare services, increases in cost savings, and additional financial commitment to curricular integration of the program. At last, with Connie's help, we were able to put each of these if-then propositions into a visual model to depict our program's theory. As you can see, the logic model intends to provide a deeper layering of our main theories into a series of if-then propositions. Furthermore, each one of the if statements represents a key linkage that can then be explored via evaluation. By creating this model, we now had a framework for what we could evaluate. The model was extraordinarily helpful to us. It allowed us to clarify the linkages that we wanted to test and to think about what questions we really wanted to study. As you look at this model, I'm sure each of you has a number of evaluation questions that you might like to ask about the program. So please feel free to type them into the Q&A box, as we are always very open to new ideas and suggestions to improve our evaluation plan. Anyway, once we had created a logic model, this is where things got even more interesting for our team, as we began to move from modeling to evaluation design. Based on our logic model for student hotspotting, we were now ready to consider which of our assumptions we wanted to test and to then develop our series of guiding evaluation questions. As a refresher, guiding evaluation questions are the questions you have about how your program works and what it does. These questions test the various linkages in your logic model. They're considered guiding because they focus the evaluation plan. The goal is to answer the questions with data. How these questions are phrased will then suggest certain methods and design. As a rule of thumb, the number and type of guiding evaluation questions you ask should take into account a few important aspects of the overall evaluation context, including the length of time your program has been around, the size and scope of the training content, as well as your own resources and capacity to conduct the evaluation. In any given evaluation plan, it is common to have at least 3 or 4 guiding evaluation questions. Each of these may have a few sub-questions. To articulate them, you might begin with a broad question, such as, did the program achieve its goals? Broad questions are important and valid because they reflect the foundation of what the evaluation should address and can be helpful for discussions with stakeholders. Next, you will want to take your broad question and begin to refine or operationalize this question so that you can more specifically focus your evaluation methods. In contrast to broad questions, which are often written in layperson speak or perhaps as part of an elevator speech, refined questions are narrower and sharper in focus. They are not written in a yes-no format, but rather allow for degrees of variation. Refined questions usually don't presume the direction of change, but allow for the possibility of multiple directions or variation. For example, if your broad question is, did the program achieve its goals? To refine this question, you might ask, to what extent did the pattern of emergency department utilization change over time for patients in the treatment group versus a comparison group? Here are some examples of some of our formative questions that we developed for the Student Hotspotting program. For one of our broad questions, we wanted to know, what is the level of student, staff, and patient interest in student hotspotting? To refine this question, we broke it down into 3 more specific questions. First, how many students applied, were accepted, and participated? Second, how many staff volunteered for the program and then stayed on as advisors for more than 1 year? And third, how many patients were enrolled and then graduated from the program? As another example, here are some of the summative questions that we developed for our student hotspotting program. For one of our broad questions, we wondered, how does support for student hotspotting develop over time? To refine this question, we asked, after 2 years, is there increased academic and institutional support for hotspotting? And after 2 years, is there increased financial support for staff positions related to hotspotting? As another example, for one of our broad questions, we asked, what is the impact on Thomas Jefferson's emergency department visits, inpatient admissions, and costs for the enrolled patient population? To refine this question, we then asked, after the intervention, are enrolled patients more likely to be linked to a primary care provider, less likely to go to the emergency department, and less likely to be admitted to the hospital? And second, does patient care become more cost-effective as a result of the intervention? Once you've spent time developing your list of guiding questions and refining each of these questions, it is important to get specific about what information or data is needed to answer each of these questions. For this section, try to get as detailed as possible. For example, if you plan to evaluate attitudes, think about attitudes towards what or about what. Or if you're interested in looking at performance, how will you define performance? By creating your list of refined questions and identifying the information needed, you can then begin to think more clearly about your data source. By considering your data source, you will want to think about certain qualifiers, such as inclusion and exclusion criteria for different people, for groups, for sites, and so on, which will have implications later on as you select your methods. In our example at Jefferson, after we created our list of broad and refined questions, we were then able to identify what specific data would be needed to answer these questions. For example, to answer our questions about how many students applied, were accepted, and participated in the program, we realized we would need information about the number of applications, our acceptance rates, as well as our participation and dropout rates. By listing the data needed, we could then think about where best to find this data and who or what would be our best data source. For this particular question, we realized we would need to access data from our academic affairs office, as well as our own internal student records. For the second question seen here, about what program elements did students find most or least useful, we recognized that we needed comments, opinions, and reflections from our enrolled students. To gather this information, we wanted to include students who participated in the program for at least 3 months and exclude students who may have withdrawn early from the program. For the third refined question listed here, does patient care become more cost-effective as a result of the intervention? We realized that we needed cost data from before, during, and after each patient's hotspotting intervention. To access this information, we would need to look at our electronic health record data and our health share exchange data during these 3 different time frames. As we listed the type of information we needed to answer our questions, we spent a lot of time considering in detail who or what might supply that information. Sometimes the answer for information source is quite easy to identify, as it may flow directly from the question stem and information type. However, thinking through this step may raise alternative or multiple sources of information that you will need to consider and choose from by reviewing the literature, consulting experts, considering financial resources, and other implementation logistics. For our information sources, we went through a number of iterations of potential options before landing on the final selection of information sources and tools shown here. For example, we wanted to measure collaborative practice skills of student practice teams from the perspectives of members on the team, as well as faculty advisors at both midway and upon conclusion of the program intervention. To gather this information, we had to consider the 47 different measurement tools available on the Nexus website and select the one that would best match our needs. We also reviewed many different tools for measuring empathy before ending up with the one we chose. As well as the same, we looked at several different options for examining burnout before selecting our instrument of choice. We were unable to find a scale that measured behavior skills and attitudes towards managing complex care patients. So we ended up adapting several other tools to try to get at this question. In addition, since we are working with medically and socially complex patients, we reached out to a qualitative expert in our College of Public Health to determine a reasonable strategy for interviewing these patients that would not require completion of mailed or written surveys. With her help, she recommended free listing interviews. By pulling together this chart of information sources and measurement tools, we were able to assemble various project leads, each of whom would really take the lead on pursuing a different aspect of our more comprehensive evaluation plan. While our team was able to pull together this draft and begin to collect data from each of these evaluation buckets, we also still recognize that this plan is fluid and that it may need to be revised based on early findings, potential challenges with data collection, financial, and other implementation factors. As you are hopefully working through developing your guiding questions, listing the information needed, and the sources you will use, it's also important to consider your methods, your analytic approach, and your approach to interpreting your data. At this point, some of the questions to consider include, first, who will collect the information? How, when, and under what conditions? Second, how will this information be analyzed? And third, what method or criteria will be used to evaluate your findings? One word of advice for designing your methodology: devote a significant amount of time to this part. Unless you are already an expert in quantitative or qualitative analysis, this can be a great time to phone a friend and engage experts at your institution or elsewhere to help you with selecting the right approach for your study. The decisions you make here will not only guide your analysis plan, but they will also determine the quality of your data and therefore of your study. As you can see on this slide, with input from internal and external evaluators, at Jefferson, we decided to use a mixed method quasi-experimental design. For our evaluation timing, our evaluation activities are structured around the academic year when the program is run and will occur annually. The calendar year of 2017 to 2018 represents cohort 1, with subsequent cohorts for the following years. For each cohort, there are T1 or pre, T2 post, and T3 delayed post time periods when the data are collected. In the upcoming webinars to be hosted by Practical Guide authors Barrett Mikulik and Doug Archibald, they will help you walk through the important methodologic considerations for your evaluation plan in much more detail. After working through this practical guide, we have learned a lot about the importance of evaluation planning in general, and particularly about thinking through each design decision before starting new IPCP implementation. Along the way, we have come to recognize that it's critical that you know your program context and theory and are able to write down all of your if-then assumptions You should also expect to go through several drafts of your logic model. In fact, we are still tweaking ours as we left out a key stakeholder, our faculty advisors, in this first round of drafts. We cannot stress enough the importance of taking the time to develop your guiding evaluation questions as a leadership team and to ensure stakeholder buy-in at this step of the design process. And finally, there is no need to be afraid to rewrite questions after data collection methods, design, and analysis options are explored. For example, it may be necessary to eliminate some questions after cost of evaluation or other logistics are clarified. Most importantly, you want to make sure that your evaluation plan is both clear and achievable. To wrap up, I hope this session and our Jefferson example has helped you to think through the design steps for your own evaluation plan. Remember to consider, first, what are the key points in your logic model that need to be tested? Second, what are your guiding evaluation questions? Third, what information do you need to answer your questions? And finally, what are your information sources? Furthermore, I hope you will leave this session today with a better sense of the decisions you need to make to move your plan to fruition. For those of us who are not evaluation experts like Dr. Schmitz, we should not fear evaluation planning, but rather, if you're willing to put the time in upfront to assemble a high-quality evaluation team, to write out your broad and refined questions, and to follow the design steps outlined in the evaluation planning tool from Practical Guide 5, you are well on your way to getting higher quality data. At Jefferson, we have actually now incorporated dedicated evaluation planning into each of our 13 ITCP programs. For each program, a program lead is now responsible for assembling a team, creating a logic model and evaluation design, and then presenting their plan to our IT research committee for both input and refinement before proceeding with their study. So far, our JPSYCH program leads have let us know that following the guide in this process has been extremely valuable to them, and that they came up with new evaluation approaches and questions that they had never before considered, as well as made new research connections and partnerships. So looking ahead, if the timing is right for you, we hope you will take advantage of the 2 upcoming webinars in this series to learn more data collection methods and analysis. If you haven't already done so, please register for one or more of them and consider buying Guide 5. In conclusion, we feel strongly that evaluation is essential for program health and well-being. Taking the time to plan for it will sharpen your program. It is also vital to this field to have high-quality evaluations, so we hope you will pursue this goal. Furthermore, on behalf of Connie and our other co-authors, we hope that these webinars and Guide 5 will help to make your job a little easier. Thank you for joining us today. And now let's discuss some of your questions, if you have them. As a reminder, please go ahead and type your questions into the Q&A box, and I will try to answer them as they come up. Thank you so much.
Thank you, Lori. This is Angela again. One question that we had a few times logistically coming through is will there be a recording of the webinar and will the slides be sent out? So I want to say yes, the webinar is being recorded. and we will be emailing the recording and the PDF of the slides to all registrants probably by the end of the week. Another question that typically comes up is, where can I buy the practical guides? So I will be pasting in a link shortly from our website.
Great. I see there was also a question about what does free listing mean regarding our patient interviews. Is it the same as open-ended? And so Dr. Rosie Frasso is a qualitative researcher from our College of Population Health, introduced us to this topic that I was not familiar with. I'm sure Barrett Mikulik, who will be doing the webinar on qualitative research, can speak to it in more detail. But essentially, it's a short technique for interviewing patients where you're able to gather information by asking them just to list all the items that they can think of that might relate to a certain topic, where it can be sort of just whatever comes to mind first, as opposed to going through a detailed, semi-structured type of interview or focus group. So you come up with a list of terms that people think about, for example, when they think about student hotspotting and their experience with their team, or with accessing their healthcare providers as a part of the student hotspotting program, and they are able to freely list and speak to their experiences. So usually the interviews, as opposed to a focus group that may last an hour, usually just last about 10 to 15 minutes.
Other questions?
So I just put up some extra discussion questions in case folks felt like responding to these. I'll also, I'm available if people want to just contact me separately. But I think some other things to think about, if you're not a trained evaluator, it can be really helpful to share in a group like this, what is the biggest challenge, what's your biggest challenge in evaluation planning? That can also help to guide the National Center in how we respond to this. How have you successfully overcome these challenges? So if folks are interested in sharing thoughts on that. One thing that I found really important and helpful in this process is how can you identify who can assist you in your evaluation plan? And if others have thoughts on how they've been able to get buy-in from other folks at their institution who may not be experts in IPE, but who might be experts in evaluation, they can add and make really great team members to bring onto a project and help you think differently. So that was one thought. And for those of you who were able to attend Connie's webinar 1 and who've looked at Practical Guide 5, I think one of the most helpful things that I found, and I thought I would just mention again, is thinking about what level of program outcomes are you looking to evaluate. So many of you are familiar with the modified Kirkpatrick typology, and trying to make sure as you're asking your guiding questions to line that up with a certain level from the modified Kirkpatrick typology. So you can say, is this something that is, level 1 and just getting at student attitudes, or is this actual transference over into practice and behavior change?
Lori, this is Angela. We just had a question come through that I'll read aloud to you.
Okay.
How much work is involved with implementing your evaluation, and what advice would you give about managing an evaluation?
That's a great question. So for this particular program evaluation, as I mentioned a bit before, we spent almost a year prepping for the scale up of the program, and I would say about 3 months in planning specifically for the different ways we would evaluate our program. With that being said, After creating the various drafts and iterations of our logic model and our refined questions, we continue to refine those. And part of it sometimes comes through, new team members join the team and say, why don't we try this? Have we thought about this aspect of looking at patient outcomes? So this can be a really helpful opportunity. We have an interprofessional research committee, and by presenting our student hotspotting program evaluation plan to that committee over 3 different seminars, we got a lot of really great feedback and input to tweak and adjust the plan. And also even through the IRB process, when we were submitting IRB paperwork to help clarify some of our methods, that also helped us to refine our questions and our evaluation plan. In terms of managing an evaluation, one of the things that I found honestly most helpful after creating our logic model was thinking about program outcomes in terms of different buckets. Since we were interested really in, to me, what I think of as 4 different buckets. So looking at student outcomes, advisor outcomes, patient outcomes, and system outcomes. And within each of these, we then listed the different measurement tools that we would be using. And we have a more detailed schematic of this where we then were able to assign different faculty as well as students who are always very eager to be a part of evaluation, planning, and scholarship. So we now have different project advisors and students who are really taking the lead on each of one of the subcomponents of our larger evaluation plan. So for me, it's trying to keep track of who's doing what and moving things along, and also making sure that the entire group connects and has a chance to hear what others are up to. Because sometimes the student advisor outcomes might influence the design of our patient outcomes, and vice versa.
Well, Lori, I think we'll wrap it up there, but we really appreciate you hosting this webinar and the rich information and perspective and experience that you've shared.
Great. Thank you so much.
So I put the National Center's email address in the chat box. Feel free to send additional questions after the webinar. We'll pass them along to Dr. Collins. And for information about the Summit short course, go to summit.nexusipe.edu. This concludes the webinar. Thank you, everyone.
Thank you.